All right. Can you see my slides? Is it working? Okay, awesome. So this is sort of a difficult lecture to give because I guess half of you only do inpatient and the other half only do outpatient. So it's really like two kind of mini talks. And I started with the outpatient stuff because I'm going to talk about some of the diabetes meds that show improved cardiovascular outcome. And so I thought that was pertinent to both groups. And then I left like the inpatient diabetes management at the end. So whoever's like outpatient can leave then if they want to or whatever. So first we're just going to talk about diabetes in general, some definitions, treatment, and then go over inpatient. So when I treat people with diabetes, they don't die from their diabetes. They die from cardiovascular disease. So like as an endocrinologist, I'm also looking at their blood pressure and making sure they're on a statin because really like the ultimate goal is to help them live their lives and live as long as possible. So cardiovascular disease results in 2/3 of the deaths in people with type 2 diabetes. And those with diabetes are twice as likely to have heart disease or a stroke than those without diabetes. So when we talk about diabetes, we talk about the macro and the microvascular outcomes. So the macrovascular outcomes are heart attack, stroke, and then the microvascular are the like small vessel disease. So the kidney disease, the retinopathy, and the neuropathy. So all the big diabetes studies, the VA diabetes trial, Accord, Advance, all of those they have never shown any improvement in the risk of a heart attack or a stroke by treating diabetes. So with treating diabetes and lowering an A1C, yes, you do prevent progression of retinopathy, neuropathy, all of the microvascular outcomes. But before GLPs and SGLT2 inhibitors, there was never a trial that showed that treating diabetes did anything to prevent a heart attack or a stroke. So in 2008, the FDA was looking at some diabetes medicines like sulfonylureas, some DPP-4 inhibitors like Januvia, and realized that some of those actually show increased cardiovascular mortality. And so now every single diabetes drug that comes out has to have a cardiovascular outcome trial to make sure that they don't cause increased risk of cardiovascular events. So this is how they showed with Empareg that empagliflozin showed improved cardiovascular mortality. So this is just a picture of some prior. Oh, thanks. So these are just all of the older trials showing that they didn't show decreased risk by taking someone's A1C and improving it from like 8 to 6.5 or 7. You didn't improve their risk of stroke, myocardial infarction, etc. And then these studies, they also looked at hospitalizations and heart failure, and they didn't improve the risk of hospitalization and heart failure. And the thought is that maybe with making the diabetes treatment more intensive, you cause more hypoglycemia, and hypoglycemia is really, really bad for cardiovascular risk. It increases your risk of death. So that was the thought with those studies. And then there's two prior medicines, the TZDs, which we don't really use much anymore, like Actos. That actually increases your risk of heart failure and myocardial infarction and increases lower extremity edema. And then there were those trials, like I mentioned, with the DPP-4 inhibitors that showed increased risk of heart failure and cardiovascular events. So this is from the New England Journal of Medicine. This is the Empareg study using empagliflozin. And this is, so the primary outcome was the risk of major cardiovascular events. And if you look at B here, you see that the empagliflozin, as you get out to 48 months, actually really improves mortality. If you look at section C, it improves, they have less risk of death from any cause. And then, of course, as you guys know, less risk of hospitalization for heart failure. So the American Diabetes Association every year or every couple of years puts out standards of care for treatment of type 2 diabetes. And they had a huge paradigm shift a couple of years ago. And I actually, last night when I was updating this, there's new 2021 guidelines. And they stratify what treatment someone should be on based on whether they have heart failure, chronic kidney disease, coronary disease, etc. So this is a little bit busy, but I'm not going to go through the whole thing. But basically, Dr. Afari asked me this too. So first line therapy is still metformin. It's not an SGLT2 inhibitor or a GLP-1. And that's mostly due to cost because they're so expensive in the United States. And a lot of people just can't afford the copay with, Ozempic, Victoza, which the GLPs are more expensive than the SGLT2 inhibitors. But actually, if you look at the European guidelines, because they negotiate their drug prices, they actually recommend doing as first line for diabetes a GLP or SGLT2 inhibitor. So if you have a patient with diabetes, the first line therapy is metformin, and of course, like lifestyle, exercise, dietary counseling. And then after that, the first question is, do they have atherosclerotic cardiovascular disease, CKD, heart failure, or are they at high risk? Do they have a family history of these? And so if they are, then you would put them on, depending on which one, a GLP or an SGLT2 inhibitor, like right away as second line therapy. And I can tell you that a lot of primary care doctors in Maine don't do this, despite the fact that the GLPs have been out for, I think, 15 years now. Some people still think of them as new medicine and are afraid to use them. So a lot of our referrals that we get for diabetes, I just end up starting them on a GLP or an SGLT2 because they haven't even been on them before. So I think when you're seeing patients in clinic or in the hospital, it would be worth it to make some sort of dot phrase that just recommends to their primary care doctors that if they have diabetes, starting them on one of these medicines will hugely help them. It'll help their diabetes and their risk of cardiovascular disease. So I can email this later if you want to look at the details, but this is a good algorithm because it actually tells you, like in the very bottom tiny fonts that you can't read, like which ones are preferred, which ones have the most data. So it's a really comprehensive information here. So if you look like in the small, it gives you just some tips for prescribing, which I'll go over in a little bit here. So then if you have a patient who's 48 with type 2 diabetes, coronary disease, high blood pressure, so sort of like the American patient, obesity, had gestational diabetes, and then diabetes came back, the A1C is 11, taking a ton of insulin, 50 units twice a day of Lantus, metformin. Tradjenta is a DPP4 inhibitor. What's your next step in therapy? So this is not, so this patient has cardiovascular disease, but not heart failure. I would probably do a GLP. And I did in this patient. When the GLP-1 receptor agonists work, they work so well for some patients. Like I've had patients with 40 pounds in them. We are able to come down on their insulin. It's really remarkable, and it has changed diabetes treatment because in the past, everything we would put people on would make them gain weight. So it's like, what's the point? You make them gain weight, then they need more insulin, and then the insulin causes them to gain weight. So you get in this cycle of like increasing medicines, gaining weight, increasing medicines. And these medicines help weight loss, which is huge in diabetes. If you lose 5% of your weight, your A1C comes down. You have much improvement in your diabetes. So this patient lost 10 pounds. Her A1C went from 11 to 7.5. We were able to come down on her insulin. Going down on insulin also helps with further weight loss because insulin's anabolic. It builds fat. Um, I already sort of said all this. So yeah, so evaluate the patient and then the GLP-1s. And I always get when I give this lecture to the residents, they're like, but they're expensive, but they're on the main care formulary. So if you have patients with main care, they can get Victoza, Trulicity, and it's free. So main care is actually awesome for diabetes treatment. They get everything free. It's the patients who have Medicare and a supplemental. They sometimes have a high copay, and some of them can't afford to take a GLP. So these are the approved GLPs. So exenatide, Byetta, has the least data for cardiovascular benefit. So I mostly use semaglutide, which is Ozempic, or dulaglutide, which is Trulicity. Semaglutide works the best, but it also has the most side effects. And so I'm sort of cautious of using semaglutide in like an elderly person or someone who I don't really want to lose a ton of weight. But I like those two because they're just once a week. So that's more attractive to people than like adding another daily shot to their regimen. And Trulicity works well. I use that for older people. There's a couple doses, and then they just came out with 2 more doses with Trulicity, 3 and 4.5 milligram dosing. So this is from, let's see, this is from a review article I found in a cardiology journal. So the GLPs work well for diabetes. They don't cause hypoglycemia, which is really helpful for us because that's just the primary thing you want to avoid in treating diabetes. So they only work actually when someone starts to eat. They affect your prandial glucoses. I have a slide that goes over the mechanism of action, but that's really attractive where they don't cause hypoglycemia on their own. However, if someone's taking a ton of insulin and you start them on a GLP, you have to down titrate their insulin usually because they will be on too much once this starts to work. So it's hard because I think that when you guys are seeing patients, for heart attacks, coronary disease, etc., you can recommend that these are started and maybe start them, but they really need sort of like co-management with their primary because they're going to need someone to call if they start to have low blood sugars and who's going to be able to tell them like what to do, what medicines to stop. Usually my preference is always to go down on the insulin because insulin is a pain to take. You have to check your blood sugar, causes low blood sugars, it causes weight gain. So that's usually my first preference. So with the GLPs, there's only sort of 2 contraindications. So if they have a family history of medullary thyroid cancer, they cause calcitonin is produced by the C cells in the thyroid. In rats, they cause C cell hypertrophy, so not cancer, but we just don't know if that has an equivalent in humans. And then they can also cause pancreatitis. So if a patient has had pancreatitis, I just counsel them about that. If they've had like gallstone pancreatitis and they had their gallbladder removed, then I still will try a GLP if I feel like the etiology of their pancreatitis has been treated. But I'll counsel them about it. And of course, I always talk to the patients and make sure they're aware of the risks and benefits. And the most common side effect is this GI nausea, vomiting. They can get worsening acid reflux too. And so because of those, we started the low dose and up titrate. So this is the mechanism of action. So when you eat, your gut releases the incretin hormones, so GLP-1 and GIP. And so these are GLP-1 receptor agonists, so they act like incretin hormones. So they increase insulin secretion from the beta cells, they decrease glucagon, they also decrease your gastric emptying. So if I have a patient who has bad gastroparesis, sometimes these aren't the best medicines because they can worsen gastroparesis. So the DPP4s, which I talked about before, like Januvia, I hate those. I never use them because they're expensive and they don't really work very well. Um, but those have a similar incretin effect, where they inhibit the breakdown of GLP-1, but these like Victoza, Ozempic work like 1,000 times more potent than a DPP4 inhibitor. So when I start those, I stop the DPP4 inhibitor because it's just no point. It's an extra medicine. It's not going to do anything. So this shows the cardiovascular trials for the GLP-1s. So I circled the ones that were significant in red. So liraglutide, so that's Victoza, semaglutide, Ozempic, and dulaglutide, Trulicity. So all three of those have been shown to decrease cardiovascular mortality with a significant p-value there. So leader, sustain, and rewind. So these medicines should really, like, everyone should be on them. But really, they're huge, right? Because what am I doing if I'm treating my patients for diabetes, but I'm not improving their cardiovascular mortality, right? That's what they're going to die of, a heart attack and a stroke. And then these are just some more Alixa, Leader, Sustain, 6, Excel, etc. And so they have shown reduction in the risk of heart attack, stroke, cardiovascular death. So these are huge. And they work really well. So if you look at Sustain, it tells you the drugs there, semaglutide. Patients lose like 5.6 kilograms, which is a lot of weight, especially in like a diabetes front. And so this is really helpful, even if they have like AFib. So like if you have atrial fibrillation and you lose weight, your AFib gets better. So not just cardiovascular coronary disease, but also AFib, arrhythmias, weight loss really helps with those too. So this is some of the dosing. I'm not going to go through the details, but I'll send this out because I'm not sure. I guess it sort of depends on what you're comfortable with, if you would actually be prescribing or just recommending. But you should sort of think of these in someone with diabetes, sort of like a statin, like everyone needs to be on a statin, and everyone with diabetes, if they can afford it, should be on a GLP. So yeah, so the most negative is that it's really expensive and also cost. And then some patients are afraid of needles too. But I always tell them, like, if you're checking your blood sugar, that hurts way more than giving yourself a shot with a pen because the needle's tiny. It's about that long. It hurts way more to check your blood sugar. All right, so moving on a little bit to the SGLT2 inhibitors. So you have a 63-year-old guy with a history of everything again, diabetes, high blood pressure, high cholesterol, heart failure, who's been hospitalized monthly. He has CKD, he's taken all these meds, he's already on Victoza. So what would your next step be? So here is where you would do an SGLT2 inhibitor, which these medicines work well for diabetes, but they're amazing for heart failure. So Adam always says, he says they're not diabetes medicines, they're heart failure medicines with a diabetes indication. So these are also on the Main Care formulary, so people can get them if they have Main Care. And Jardiance and Farxiga are on, and those are the ones with the best data for lowering your risk of hospitalization with heart failure. So how do these work? So the kidney usually filters about 180 grams of glucose per day, and then it's reabsorbed in the proximal tubule by SGLT2. So it blocks the reabsorption of glucose, so you just pee out more glucose, basically. So this also works pretty well and doesn't cause hypoglycemia because it's just blocking reabsorption of glucose. It's not actually like increasing release of insulin. And so these only work when your blood sugar is high. So these are some of the cardiovascular trials. So overall major cardiovascular event in empagliflozin and canagliflozin, so Credence and Canvas, showed significant improvements in cardiovascular death. So I think sometimes people forget about this, but even if you don't have heart failure, these SGLT2 inhibitors still decrease your mortality, just like the GLP-1s. So if you have someone with coronary disease and they don't want to give themselves a shot because they're afraid of it, you could still put them on Jardiance, and that would still help if they have diabetes. And then this is where really these medicines are amazing. They decrease the risk of hospitalizations for heart failure by a ton. Let's see. And we don't, so here's the thing. So we don't really know the mechanism why these help patients with heart failure. There are a lot of proposed mechanistic effects. Maybe they act sort of like a diuretic. Maybe it's a little bit of the blood pressure lowering. It's probably a combination of all of the above. But it's interesting because SGLT2 inhibitors improve mortality even if they don't affect your A1C. So it's not because they improve your diabetes, they have another effect. And that makes sense, right? Because they're improved now in people who don't have diabetes for reducing risk of heart failure exacerbation. And they're amazing with renal outcomes too. So they delay progression to chronic kidney disease in people with diabetes and proteinuria. So these are the renal studies, Credence and DAPA-HF, that just show amazing outcomes. So if you prescribe these, so you're probably prescribing SGLT2 inhibitors a lot more than you are GLP-1s. So acute kidney injury, so they do get a transient decrease in their GFR. So I usually check a GFR a couple weeks after I start these. If it's a little bit lower, I usually continue and then check again. But I've had patients whose GFR gets cut in half, and so then I stop, and then I stop their SGLT2 inhibitor. The other thing to be worried about a little bit is that they can cause DKA. The worry about this too is that recently we had a patient we consulted on inpatient who was admitted and had heart failure. They wanted to start one. We were following them for their diabetes. And we said that this patient we think actually has type 1 diabetes, not type 2. So we wouldn't start an SGLT2 inhibitor. So don't start them in type 1 diabetes because they increase the risk of diabetic ketoacidosis. Even in type 2, sometimes they counsel them about it. Like if you're sick, you're throwing up, you're just really, really sick, like you can always call us. We would check a BMP to make sure you're not in DKA. And then one study showed with Invokana or canagliflozin increased risk of lower limb amputations. And it has not been shown again, but there's this one study and we don't know why. So I am nervous. I don't use Invokana if I can help it, because that's the only SGLT2. And I definitely don't use Invokana in someone who's had prior amputations. I try and use Jardiance, and I counsel the patients and just let them know about it. So overall, Jardiance has the best data. It does have renal benefit, but sort of off-label. I think the prescribing guidelines will change, and nephrologists are recommending these more and more too. But I usually don't start or continue if the GFR is less than 45. That is the same with Invokana. With these medicines, I worry a little bit about elderly people because they can lead to dehydration. So I just, we used to cut back on their diuretics. Like if they're taking hydrochlorothiazide and starting this, you would stop it or cut back on it. I don't do that as much anymore, but I think I might think about it if I'm starting this in someone who's 70 and frail or whatever. I also give people sick day guidelines for these SGLT2 inhibitors. Like if you get a viral illness, you're vomiting, you have diarrhea, you should stop these until you're better and then restart because they'll just make you more dehydrated. It's probably similar guidelines that you give for people on diuretics who don't have like severe decompensated heart failure. Yep. So then this is just an example here of a 33-year-old female with diabetes. She's on metformin, dapagliflozin. She has increased urination and abdominal pain. So if you look at her labs, her bicarb is 14, and her GAP is 19. So this is an example of DKA. The caution with this, though, is because these medicines are still working even when you're in DKA. You're still going to be peeing out your glucose. So they present at a lower glucose than a traditional DKA who's not taking insulin, right? Because you're still peeing out the glucose even if you have like a total body deficit of insulin. So I counsel patients because this gets missed sometimes in the emergency room because they would look at that and say your blood sugar is 180, you can't be in DKA. So I do counsel patients about this. And it's called euglycemic DKA. It's rare, but it does happen, and it's higher risk in people with lower C-peptides, and the C-peptide is a marker of your own endogenous beta cell function. This is cost, just to give you guys an idea, because I think it's really hard for the patients because sometimes they're paying like $600 like every 3 months for their medicine on top of what they're paying for all their other medicines. So if you look here, the GLP-1s are crazy expensive, like liraglutide, Victoza is like $1,000 a month. So they can be crazy expensive for some patients who have Medicare and are on like a limited income. There are treatment programs, of course, if they have private insurance, but if you have Medicare, you don't qualify for the like copay cards. Any questions about that? It was sort of like a whirlwind about patient diabetes / cardiovascular. Nope. Okay. So now I'm switching gears to inpatient treatment of diabetes. Like, what are the goals? Where do you want to go? Are there different goals for cardiac patients? And then a little bit about discharge and then pumps. So we have a 35-year-old guy with history of diabetes, admitted with pneumonia or a heart attack or whatever, an NSTEMI. He takes Lantus, Victoza, and metformin. His A1C is 6.7, so he has well-controlled diabetes. We started him on an insulin regimen. So what are the inpatient glycemic targets? Anyone know? All right, so let's look at the Cardinal study here. So this is the glucose level in the first 24 hours after an acute myocardial infarction. So you'll see here that if you go from left to right, as the blood sugar goes up, the mortality goes up. So after this study came out, everyone started to be really aggressive about lowering blood sugar in the hospital. And then the NICE sugar study came out, which was in the New England Journal of Medicine. And this looked at conventional blood sugar control less than 180 versus intensive. And the intensive arm was 80 to 100. And the people who had more intensive glucose control in the hospital had decreased risk of survival. So this showed that it's 80 to 110 is not good. Hypoglycemia is really bad in the hospital. So then there was a couple other studies looking at tight group, moderate group. These were people with known diabetes who were undergoing coronary artery surgery. And they found that the moderate group had the lowest mortality. So both the liberal and the tight group had increased mortality. And their moderate goal was 127 to 179. So the inpatient goal is about 140 to 180. When I see like a fasting glucose of 80, I get nervous and I go down on their treatment because you really, really want to avoid hypoglycemia. Patients with one blood sugar less than 50 have increased inpatient mortality. And 84% of those with a blood sugar below 40, so like 35, had a prior episode less than 70 during the same admission. So you can predict it. If they are having blood sugars in the 60s, you really want to de-escalate their therapy because the next one that's coming is going to be 35. And people are, they're feeling sick. They don't recognize hypoglycemia as much as they would in an outpatient. Maybe they're on pain medicines, other centrally acting medicines. And so they are just at such risk of having prolonged lows. because they don't get checked. They get checked on a couple times a day. So you just want to avoid hypo and then severe hyperglycemia because, of course, that impairs wound healing. This is really important after CABG. So good glycemic control decreases the risk of mediastinitis after someone has a CABG. So the goal is 140 to 180, and really the fasting should not be any lower than 90 to 100, preferably 120, but it's going to go up throughout the day a little bit. So if it was like 100 to 110, I probably wouldn't change anything. And if they're elderly, we have some patients we've had in the hospital lately who are so brittle, and we just want them to be 200 because our goal is no low blood sugars. So right before cardiac surgery, there is data that shows if you have a stricter glycemic target, it does reduce mortality. The Cardinal study was looking at post-MI, but this is post-cardiac surgery. So, we still suggest 140 to 180. Some people shoot a little bit lower, 120 to 160. But there actually are recommendations to start an insulin drip when the blood sugar is greater than 180 in patients with MI and a complicated course, which that would be up to, I guess, us to determine what a complicated course is. So 57-year-old guy is admitted for chest pain. He has diabetes, coronary disease, etc. He manages his diabetes. He's taking a bunch of meds. His blood sugars are 170 to 210. So what would you treat him with? So the answer is coming. But basically, I just put this in here because I tried to give you like a lot of references to come back to in this lecture. So these are just the main medical center formulary contraindications to inpatient use. So basically, you really only want to use insulin in an inpatient. You can continue their metformin, but if they have any liver disease, they're going to go for like contrast, like in a cath. You probably want to stop their metformin because there's increased risk of lactic acidosis. I hate sulfonylureas in the hospital because all they do is increase the risk of low blood sugar, and people are not eating as much as they eat at home, so those are pretty risky. So here I wanted to point out SGLT2 inhibitors from a diabetes standpoint. We don't recommend using them to treat their blood sugar, but you guys probably start them to treat heart failure because there is data that shows starting SGLT2 inhibitors prior to discharge helps decrease risk of hospitalization. But in terms of diabetes treatment, you would use insulin, but if they have heart failure, by all means, start them. So really insulin is the mainstay of inpatient hyperglycemia. These are just the types of insulin, how long they last, etc. Be really careful with 70-30 and 75-25. So that has both long and short acting insulin. That's really hard in the hospital because you can't titrate their basal and their mealtime insulin separately. So if someone is NPO, not eating, I would just switch them over to the equivalent of like glargine and then mealtime insulin because that never goes well, usually using mixed insulin in the hospital. So how do you use insulin? So this is just a point to make. So if you have someone admitted, she has diabetes for pneumonia, her metformin and glipizide are held, she's starting on sliding scale insulin. So we have a lot of tools at MaineMed that help prevent this, but sliding scale insulin by itself is not helpful. So there's one study that showed it's increased with higher risk of hyperglycemia and hypoglycemia because sliding scale is just reacting to the high blood sugar, but really you want to prevent it with mealtime insulin, basal insulin. So the patients who are just on sliding scale had longer hospital stays and more hypoglycemia, and their hyperglycemia was not controlled. So we prefer basal bolus. So there's just improved glycemic control with this, with just sliding scale without an increase in low blood sugars. So we have a really good order set that sort of helps you guys choose the doses: basal, prandial, and correction factor. So it's right here. Oops. Delete. So I think it's pretty helpful because it defines low dosing, medium, high. It gives you some like guidance when you're starting insulin as to what doses to use. And then the order set, endocrine was not involved in creating this order set. So it is really cumbersome, but if you go all the way to the bottom there, you can change the carb ratio, the correction, mealtime, etc. So how do you convert from home to hospital? So these are some guidelines. If it's type 2, we usually reduce their dose by like 20%. NPH, the same, reduced by both doses by 20% usually. And then if they have they're on steroids, etc. I mean, you guys can always get us involved, but we tend to stack more of their insulin towards their mealtime. And then with renal failure, just be careful. If someone comes in acute renal failure, I would go down on their home insulin regimen because the insulin will last much longer. And then this is also sort of like a good reference. So people get really confused about this. When you say 1 unit of insulin, that means 1 unit of insulin. So when someone's on concentrated insulin, like Toujeo, which is U300, and they're taking 50 units, that's still 50 units, but the insulin is concentrated, so they just get less volume of insulin. It's not like you have to multiply by 3, it's all about the volume. This is also true for U500 pens. We would please like you to consult us with U500 because it gets confusing for everyone, the nursing staff. So it gets really confusing because if they have a U500 syringe at home, they may be taking, like if they tell you they're taking 20 units, they might be taking 20 unit equivalents. So just consult us with U500 because it does get confusing and it can be really dangerous. And then Tresiba is one of the newer insulins, but you can convert it 1-to-1. If they're on 20 of Tresiba, you can put them on 20 of Glargine here. Good. So let's see. So then this is just like a couple questions on how to titrate. So if you have a 30-year-old pregnant, type 1, admitted for glucose control, these are her numbers here. So she's on 18 of Glargine, and then she was 63 at 4 a.m. How do you titrate her insulin here? Would you go down on her Lispro or her Glargine? I would probably go down on her Glargine because when someone has both hyper and hypo, my priority is always to get rid of the hypo and then reassess. And then you can always add more mealtime if that's what caused her 200s over here. Yep, so you can adjust the Lantus, preprandial. It's really hard in the hospital too because when you're looking at someone's blood sugars, it's not always how it looks. Their blood sugar might be 400 because they didn't get their mealtime insulin. And so then you don't need to change their doses, they just need to get it. Sometimes people will give their mealtime after they eat, and so that's dangerous if you correct based on their high blood sugar, which is resulting from their meal intake. Really, you should be taking their blood sugar before, correcting based on the preprandial, and then giving them for their carbs. So a lot of inpatient glycemic control boils down to nursing education and whether they're holding the insulin when they shouldn't be, whether they're timing it correctly. Great. So now what about this patient? What about this guy? How would you titrate his insulin? So he's on 50 of Glargine and then some Humalog 30 units with meals. And at like 4:21, he was 36. So I would probably go down on his mealtime there. That's really low. You want to go down by 20% when someone has a low blood sugar. So I would probably go down on his Lispro. Maybe what happened sometimes. So the nurse gave him enough for 60 grams of carbs, and then he only ate 30 grams of carbs. So if that happens, they're supposed to give the patients like some sort of food, juice, some sort of carb to get them to 60 grams of carbs. But I think they're so busy that it's just hard to keep track that closely. Good. So this is just giving you some information on how to titrate insulin there. Okay, so I think we're almost done because I wanted to leave time for questions in case you guys had any. So I did find this because sometimes we get consults for people who have had like heart attacks or NSTEMIs, had a stent, whatever, and then they're going home, but their A1C is high. And so the question is, it's correct that if their A1C is high, their home regimen should be escalated. They shouldn't be discharged on just what they came in on unless they weren't taking it. And so this was a study done by Perez, who does like all of the inpatient diabetes studies. He's at Emory. He does like every single inpatient diabetes study. And they randomized patients to just like this algorithm where if your A1C is 7 to 9, you got discharged on 50% of the inpatient basal. And if your A1C was greater than 9, you got discharged on 80%. And they found that it worked pretty well and they didn't have hypoglycemia. So this, just shows that maybe we could form an algorithm. We could work together if you guys wanted to form some sort of algorithm to escalate their therapy on discharge, or some sort of information to give for their primary care doctor saying like they should be on a GLP-1, etc. And then pumps in the hospital are just going to be more and more common as time goes by because pumps are better and people don't have to be as savvy with diabetes as they used to be. Because they used to have to be really good carb count, check their blood sugar all the time. Now they can wear a blood sugar monitor and the pump and not be as, I don't know what the word is, and not be as exact with their carb counting, etc. So it's just going to keep coming. So these are what some of the pumps look like. Right here in the middle, this is the Omnipod. So this is the only tubeless pump we have. So there's a pod that has insulin, and then that's their PDM that has all their delivery settings. And then this one is the newest algorithm, the Tandem T-Slim, that works with the Dexcom, which is a blood sugar monitor. So the patients still have to count their carbs and tell their pumps when they're eating. But the pump delivers a continuous burst of short-acting insulin. So if their pump gets taken off and they have type 1, they need to get the pump back as soon as possible or get a shot of like glargine or long-acting insulin. Otherwise, they will go into DKA. This happens a lot when people go down for surgery, MRI, some sort of imaging where they have to take their pump off. They come back, they're sedated, people forget to put it back on. It happens a lot. We're trying to come up with sort of like a flag in Epic that says like this patient has an insulin pump, because I think it's easy to forget about it and just not be aware when they have other things going on or they're sick or something happened, when you're treating their acute medical need. There have been pumps that have been taken off and lost in the hospital too. That happened a couple weeks ago. And an insulin pump costs about $5,000. So the hospital is paying for that patient's replacement pump. So these are really expensive. So if a patient is taking their pump off, I try and give it to a family member and say, like, take it home, take it out of the hospital so it doesn't get lost. And then these are the continuous glucose monitoring systems, the Dexcom, the Freestyle Libre, which a lot of people with type 2 have, etc. So inpatient, there aren't any randomized studies using continuous glucose monitoring, but we always let people keep it on. we just make them check their finger stick with the hospital meter, so we have that documentation. But I think it's better because if someone who has a lot of low blood sugars, this will alert them before, instead of having to like use their call bell, ask someone to come check their blood sugar. How that probably takes like 15 minutes. So this way it helps them be safer in the hospital, because really most of this talks about type 2, but when you have type 1, the hospital is a really, really dangerous place to be in. Usually the patients are much better at taking care of their diabetes than we are. And they usually do better when they do it. So yeah, so the requirements for pumps used to be pretty strict, but now a lot of people who are sort of non-compliant, we're just putting them on a pump with a closed loop. So the Tandem adjusts the basal. It stops if their blood sugar is dropping. It boluses if their blood sugar is going up. So it just makes it a lot easier for people to have diabetes. So I think pumps are just going to keep becoming more and more frequent in the hospital. And so we're trying to figure out what to do, because at some point we won't be able to see everyone who comes in with a pump, or maybe we'll hire more. I don't know, we'll have to see where things go. So that's all I have. So what questions, or was there something about diabetes and cardiology that I didn't address that you wanted to hear about?
Dr. Caldwell, it's June from one of the transplant coordinators. So I just wanted to confirm, essentially. So you said after 2 weeks after roughly 2 weeks after starting an SGLT2 inhibitor is when you would check a BMP to check for GFR?
Yeah. And I think in talking to Adam about this, you sort of just use them like a diuretic, you know what I mean? Like, like I'm like, oh no, I'm going to cause a decrease in GFR. And he says, I mean, I give people like Bumax and metolazone all the time. But I usually check, a couple weeks afterwards. And then if they have a decline in their GFR, sometimes I'll still continue and then check a couple weeks after that. And it does come back up to normal sometimes. But depending on, there's no guidelines that say what your threshold should be to stop it. I think most people would stop it if it's below 45. But if there's a little, bump in the creatinine, I tend to just ride it out and continue it, because now we also know too that they're renal protective. So it's sort of like an ACE inhibitor or an ARB. You do have a decline in the GFR, but overall decreased progression of their kidney disease.
Thank you.
Yeah. Any other questions? I can email this PowerPoint if you guys want it as a reference. Let's see, is there someone? Okay. Okay. All right. Well, if that's it, then thanks so much. Have a good day.
Thank you.